I'm Joanne Quan, Chief Medical Officer at Mirum Pharmaceuticals. FOP is an ultra-rare genetic disease, very rare, probably only 300 or so patients have it in the US that have been identified. And it is due to a mutation in a particular gene in a pathway that's important in bone formation. So the gene is called ACVR1 or ALK2. And this particular gene is always active in patients with FOP, which means that they actually form bone in very soft tissue, so muscles, tendons, ligaments, places where people who are normal don't have bone formation. What this means is that patients from a very early age will develop areas of inflammation, and then many of these subsequently go to bone formation or what's called heterotopic ossification. And over the course of time, it causes progressive disability. You can imagine immobility in joints, immobility in the jaw, and therefore difficulty eating, things like mobility, just able to walk, to breathe, so the chest cavity becomes immobile, and therefore patients get susceptible to pneumonias. And so often these patients are in wheelchairs by the time they're in their 30s. They're susceptible to falls because they can't break their fall by extending their arms. And also the median life expectancy is in the mid-40s because of the thoracic kind of restriction, essentially. So a pretty impactful disease from both patients and families and obviously caregivers. It's a pretty difficult pathway, but kind of put very simply, the gene is always active in patients with FOP. And so we have an inhibitor of that particular kind of activity of that receptor. So I think very simplistically, the gene is always active in those patients. We're trying to kind of tamp down that overactivation. So the zilurgisertib is really appealing because it directly attacks the physiology of the disease. So it's an inhibitor of the receptor. So from a pharmacologic basis, it inhibits the receptor. And what we've done in the clinical trials is to kind of play that out with patients to show that it actually affects, decreases new HO, new bone formation. The PROGRESS trial is a double-blind randomized placebo-controlled trial. And the first cohort, what's called cohort 1, has treated 63 patients, adolescents age 12 and up, adolescents and adults, a global multi-center study, as you can imagine, with a rare disease. And that looked at 24-week treatment with either zilurgisertib or placebo in a blinded fashion. And in that, what we showed was that there were fewer patients who had new heterotopic ossification, less volume of new bone formation, and all of the patients after 24 weeks, including the ones who were in placebo, were put onto open label treatment. And we actually see those same effects play out in that open label treatment. So a lot of consistency in terms of the endpoints that we're looking at, both in the double-blind portion across the various different measures of HO, as well as looking at what happens to the patients when they come on to open label extension. So the flares were measured during the trial. And actually, this decreased the number of flares that occurred in those patients in that 24-week double-blind period. So it does appear to decrease the number of flares, which then also decreases the number of heterotopic ossification. Well, the way that we're approaching it from a development point of view is somewhat cautiously. So the initial cohort 1 enrolled patients 12 and up. And then we're stepping down in age. So we're going down to 2 other cohorts with progressively lower ages. And some of that is just, we're very cautious in children. We want to generate data in adult populations before we go to children, make sure the dose is correct, make sure we're measuring the right things. So that is the natural course of how this study is designed. And we have 2 additional cohorts looking at pediatric age populations to ensure that we have the correct dosing, that it's safe, and we see similar types of results. So the study was designed from the outset with an adult cohort, the cohort 1 to start, and then finishing that and then going to cohort 2 and cohort 3. So those are already sort of ongoing. Of course, there is a little bit of lag of time, and I certainly understand some frustration with that. But I think we're trying to balance, and Insight was really the company who designed this, trying to balance, trying to get things out there quickly with, some level of caution, given that we're treating younger patients, they could be treated for a number of years with this drug. And I think there certainly is a lot of urgency within Mirum and within Insight over this program. As we've gotten to understand the disease and understand the impact on patients and families, there's a lot of kind of understanding and just momentum to try to get this out to the patients as quick as we can. We're partnering with Insight to do this, right? So they have the lifting and are continuing. We're working with them at this point. And in the conversations with FDA, FDA has agreed that this can be filed. So they're reviewing the data at this point, and we have a PDUFA date September 26th of this year. So those are all really positive, indications that the FDA is realizing that there's a big unmet need and that this data is compelling. Obviously, we have to see exactly how they look at the overall data set, and we'll be in conversations with them. So the relationship is that we will be commercializing it, and that's really exactly up our alley in terms of our focus on rare and ultra-rare disease. This fits in really well with our pipeline and the folks that we already have out in the field. And it's a very targeted kind of patient population. There's a great patient advocacy group, IFOPA, that's involved, and they've really helped the community kind of mobilize themselves, help enroll them in the study. They're giving us some insights into the patient community and how to communicate with them. So this has actually been a great partnership. I think there's doctors of kind of different kinds, right? I think on the one hand, we want to encourage patients with FOP to get diagnosed sooner rather than later. And in a disease like this, there's a very characteristic toe malformation, which if you've seen it, then people will recognize, and it kind of rings a bell. It's because it's a rare disease, people may not recognize that. So I think that's one of the things, that there should be some broader education for people to recognize that, okay, something is happening here, and they don't know what it is, they need to refer it, genetic test will pick it up. So that's kind of for a general physician. For someone who actually treats FOP, the trials are limited in number because the disease is very rare. We will be continuing to follow these patients in an open label extension. We routinely, for all drugs, including rare drugs, monitor things once they get into the market, and we'll be kind of sharing information as is relevant. So I think that the information that we have currently based on the progress study in the phase 2 is actually a substantial data set to be able to evaluate, does this work? Is it safe? That's currently what the regulators are evaluating. So I think, especially when we think about how acute the need is for treating this disease, I think that we feel good about the data that's in the regulators' hands right now, that they can evaluate the safety and efficacy and make an appropriate kind of risk-benefit evaluation.